Uh, Good evening, ladies and gentlemen. This is the webinar which we usually conduct every month, and this is a webinar which people can register as a complimentary or free by invitation. And we have international speaker. This is done under the aegis uh, of the Innovation Curious Foundation for Healthcare Excellence, where we have the activities which are not for profit activities, and these are the webinars and other few initiatives. In the last, I will show you also what all the initiatives we are having. I welcome everyone for this webinar. The subject is, can the potential mechanism by which an innovation brings value be identified in advance? Now, everybody, there are two resource people. One is from Finland, Professor Paul, and another one is from India, Dr. Agrawal. To introduce the subject, it is something which we would understand. It is something to do with the business model, that when you want to do really some innovation, can you think that in advance while you're making such model, that what kind of value it can bring on the table? And Paul is the main resource person. He has done a lot of work, written a book on that, that a demand supply based operating logic. In fact, he is also co-editor of book which was done by me in on healthcare innovation. Now, to introduce Professor Paul, is the professor in the Aalto University, and he has many things to his head. It is in addition to that, he is doing many other work as far as in India is also concerned. I've conducted some training programs with him on healthcare innovations in IIT Kharagpur and NIT Raipur. So he's quite well versed as far as India is concerned. I introduced Dr. Vijay Agrawal, good friend of mine, who is very senior person, is into the profession for many decades, for last 4 decades. He is the president of a consortium of accredited healthcare organization, advisor to Max Healthcare, and is a focus on quality and a business excellence. He is an advisor to the Global Association of Physicians of Indian origin. So you would find that the people who are expert in the subject will be talking on the issue. The flow would be, I'll hand over to the Dr. Vijay Agrawal to moderate the session, and he'll conduct the session where Paul will make presentation in the later. You can keep typing your questions, and in the last phase, Dr. Agrawal will take these questions and pass it on to the speaker, and he would answer, the answers will be given. And the end, I'll again come to thank all of you, and we will also like to have your feedback later so that we can do what you really want to hear and see on the subject. Thank you very much, viewer. I can see that a number is swelled up and people are still joining in. And I'm sure in 5 minutes, most of the people would have joined. It is around 30 people at the moment, but every time the number is changing and adding anymore. Thank you very much, my resource people. Thank you, Dr. Vijay Agrawal, that I hand
Thank you,
over
sir.
to you to moderate the session and carry on. I'll come in the last just to conclude. Thank you very much. Over to you, Dr. Vijay Agrawal.
Thank you, General Dr. V.K. Singh. Dr. V.K. Singh, who himself is an icon in our country in the field of innovation. So, actually, for this topic, he was the best person to also oversee, supervise, moderate. Very kind of him to have asked me to do something. Am I audible?
Yeah, yeah, you are audible.
Okay. So,
Thank you.
uh, about Paul Lilrank, I have had the pleasure of listening to him earlier in one of the training programs. I have read his book on the logics of healthcare. And all I can say is that I find Paul as one of the original thinkers of the subject. And I would say that the biggest innovation probably he did was that when he was suffering from a complication of appendicitis, and at that time he was not from the medical field, he has been a social scientist, he has been in the field of operations, and therefore he was thinking as to what things were going wrong during his care. And that is what has, I would say, stirred up things in his mind and has led to, I would say, output which is helping all of us in healthcare. So I'll not like to stand much between you and Paul, and I think the topic itself is very, very exciting, and no other person other than Paul himself can introduce and start this topic. So over to you, Paul.
Okay, thank you. Thank you, Dr. Agarwal. I hope you can hear me over this very long distance. I'm sitting in Helsinki right now. It's 1:30 in the afternoon, and we have 50 centimeters of snow on the ground. All right, let's get to my subject. I'll open the PowerPoint. I hope you can see it. So move to the first, or let's say the second page after the introduction. Okay, so we want to talk about innovations, innovations in healthcare. Now, everybody understands that we need innovations in healthcare very much, given the, I would say, sorry state of health service production all over the world, regardless of the level of spending. So nowhere is there a system where all stakeholders, the patients, the providers, the politicians, and payers could be satisfied with what they get. So we have a job to do. But going into that, it's a good, or let's say, essential academic practice to define your concepts before you move on. So let's spend a second thinking about what is innovation. In innovation research, the standard definition is what you see here is on this picture. Innovation is a combination of something that is new, so there has to be a novelty aspect. That novelty must be repeatable. So a flash in a pan, so the one time occurrence is not an innovation. There has to be a repeatability thing. I mean, you must be able to document it and turn it into a process or routine or whatever. And then third, the innovation needs to be useful for the innovator and for the user. This is a pretty strict condition here. Many of the things that are called innovation that come from the government typically do not fulfill this criteria, because there is no way to really judge whether the new thing is useful or it's useful to the extent that somebody wants or is willing to pay for it more than it costs to produce. So anyway, the question with India, by the way, is that I'm not sure how much we need to stress the novelty side here, because India, as well as other developing countries, are growing rapidly as a result of the catch-up effect. So catching up from more advanced countries that can keep sort of progress going for quite a while. Innovation becomes a desperately pressing problem then when you hit the innovation frontier, when you are sort of out there with no one to learn from. You have to do everything yourself, take the risks, do the trade-offs, and carry the costs of failure. So that's why economic growth in advanced countries, Europe, North America, and Japan has slowed down, because at the frontier, things are hard. So in India, you still have a lot to catch up. But anyway, what is new then? I mean, there are different new things. Things can be new to an individual. When I learn something from you, then it's new to me. there can be things that are new to a discipline. And this is what happened when industrial management methods that were sort of an old hat in the car industry were applied into healthcare. So it was new things to the discipline. And then, of course, finally, we have the things that are new to the world. So we can say that anything that you haven't seen before is new to you. And even if it's not new to the world, you have to sort of treat it as a new thing for you. And by that account, it can be an innovation. All right, then everybody wants innovation. Why do not we have more of them? With innovations, I believe you can say or think of them like we think of, let's say, love and happiness. There are things that come and go following their own logic. If you try to pursue happiness desperately, you will certainly be unhappy. But sometimes happiness is a byproduct of doing something else. So these are sort of ethereal things, difficult to define and capture. But anyway, there are some regularities that we can see in the field of innovations, and particularly when you go to a sector like healthcare, then there are more regularities to be seen. And it's the first sentence here on this PowerPoint is sort of version of the very famous Anna Karenina principle. That is the starting line in Tolstoy's roman War and Peace, Anna Karenina. It says that all happy families are happy in the same way, while every unhappy family is unhappy in its own way. So twisting this a little bit, we can say that all failed companies are similar, but all successful companies are successful in their own ways. So the failure that makes all the failed companies similar is, at the end of the day, it's just lack of money. And before that comes something that you have alienated your customers or whatever. So from that, I think we can say that it's worthwhile studying innovations if you are the innovator, in order to avoid the typical and unnecessary failures. In management studies, I repeat, it has not been possible to elicit a general success formula. There's no such thing. But there is a generic failure formula. So failure is easier to understand. So learn about the failures and don't repeat them. Then to those who promote innovations, like say funding agencies, scholars or so, it's worthwhile to understand innovations, because many times the innovators themselves do not have full grasp of the potential that the innovation might entail. And then to the users, and here I think of all the hospitals and caregivers who might use some new interesting digital technologies or whatever. For the user, it's imperative to think hard and figure out what are the benefits of applying a potential innovation in your work. There are first order and second order benefits, and they are not always very easy to identify, but need to try. All right, then I propose that innovations can be understood by using two analytical frameworks. The first is the DSO, that is the demand supply based operating logics model. For an innovator, it says that health service production is not one industry. You cannot think of an innovation that would apply equally all over the place. Healthcare, according to this model, is made out of 7 different businesses. So you have to ask yourself, in which of them would your innovation work? Then the second perspective is the business model canvas. This is a very elegant way to describe a business model by its constituent parts, of which there are 9. This is a good exercise to always think, what do you offer? To whom? How do you reach them? How do you relate to them? What resources do you need? What do you do? What are your processes? With whom do you need help from or partnering with? What does it cost? And who pays you for what and how much? I mean, here it is. Everything else is elaboration on this model. Okay, both of these models are very profound in the sense that going deep into them would take a day to explain. So let me just very briefly run through the basic logic. The demand supply based operating mode tries to identify segments in health service production that are from a management perspective similar. So we are not talking about things that are from a clinical perspective similar, that's a bit different ballgame. So we run through this algorithm, starting classifying patients and ask if the patient ill, is the risk realized? If no, then we can continue asking, well, but do you have a elevated risk level? If yes, then you are a case for prevention. So you are not yet sick, but you will soon be if you continue your life as it is. Okay, but if you are obviously ill, then the next question is your case urgent? If yes, then you are an emergency case. If no, then we have to ask, okay, can we help you here and now in one uninterrupted sequence? If yes, then you are at one visit. Typical, like say, dental care, deals with a lot of these kind of things. If it's not treatable in one visit, it means that you have to come back again. And that means that the whole thing turns into a process. A process has two or more parts that need to be connected. So now you are in a process. So we'll ask you, can we use, do we know what to do or set up the process? Can we use a routine? If yes, then we ask, well, how precise can it be? If you can schedule it clearly, then we talk about elective medicine. If it's not schedulable, and then we ask, is there a predictable or desirable endpoint? If yes, then we talk about cure processes. Like say, think of complex cancer. It's a situation where you start the process, but you don't know how the process will go from end to end. You have to find your way. It's an explorative process, very similar to research and development. While then the electives is more like a car factory where you sort of follow very strict routines and maintain the quality. If there's no predictable endpoint, then you are in continuous care. Then we have finally the thing that if there's no routine process that you have in your own organization, you might have to band together with some other, and the patient turns into a project. So here we have the 7 different businesses. So we can think of it. Emergencies are similar in the terms of how you manage an emergency center. It doesn't really matter if the emergency is from a car accident or poisoning or electrocution or drowning or whatever. The key point is that there is not a lot of time. You have to do things quickly. In prevention, it doesn't really matter if we talk about, say, maternity care, where we try to prevent something bad happening during a pregnancy, or we talk about elder gentlemen who are in the risk of prostate cancer and we want to prevent that. Prevention has its own logic, its own kind of business, regardless of the clinical content. Okay, I'm not going to read through this, but I'll leave these pictures for you so you can think for yourself of the demand for service and the supply, what can be done, how they sort of split along these DSO categories. And here one more. Time is important in all kind of production. So you can ask yourself, what is the time orientation, time perspective in these 7 DSO categories? You see they are very different. And then you can also think that there are different industries that you can benchmark to. I mean, if you are interested in emergencies, the military and law enforcement operate very in a similar way. Prevention, that's what insurance and finance people do, and so on and so forth. Okay, that's that. Then we go to the business model canvas. The business model canvas puts these questions that you can see. First, it asks, what is it that you offer? What can your innovation do? What is the value of it? Then you ask, well, who are your customers? Whom do you think this value applies to? Then you need to ask, How do you reach them? Which are your channels? And once you reach them, how do you relate to them? Do you have a continuous relationship or not? Then here on the left side, we talk about production. So what are the resources that you need? What kind of assets do you have? Then the key activities, and this is what lean healthcare talks about. What are your key processes? How do you operate them and improve them and measure them and all that? And then your partnerships, whom do you deal? Your suppliers or regulators or whoever that is important for your business. Then the cost structure, which things cost how much? And the revenue model. How do you get paid? Who pays you for what? This is for many businesses very crucial because there are several different potential revenue models. Okay, when we talk about healthcare, then we can run through the same questions. We have a couple of examples. The value proposition, new cures and therapies. You might find a new underserved segment. There might be ways to reach out to patients in a new way. You can build new types of relations. This, by the way, is very important in continuous care and prevention. We've been experimenting with that. I mean, if you have a person with a chronic condition, you should not let go of that person, but manage that as an inventory. Then the resources, for example, different kind of personnel categories that can be used. And then this is the process part. And there's kind of networks and synergies. I mean, these are the areas where you can think of new things. And then the cost structure. In almost all service production systems that I know of, there's a lot of slack, and I've seen places, some of them in India, where without really sort of compromising quality or even bring a sweat, you can take out 30, 40, even 50% of the cost. That can be done. And then this revenue model thing is very interesting, also in India, because there are many ways to get paid out of pocket, various sort of insurance models that is a fertile field for innovations. Okay, if you want to go deeper into this, then I suggest you spend at your leisure some time looking through this matrix, because here are the DSO categories and then the business model canvas categories. So what I want to say here is that if you think of something innovative, and try to find its place on this matrix. So where would it operate? Perhaps in more than one, but if you find so that the primary cell where you would sort of think that your innovation hits there, then you got to try to understand what is the dynamics of that business. If you talk about, say, one visits and customer channels, then that brings into the questions of retail locations, booking systems. Where do you put your stuff? Do you have enough foot traffic there? How do people come to you? Is there a bus stop nearby? And so on and so forth. Okay, the DSO model is a rather complicated way to do the segmentation exercise, but there are a lot of ways to so apply the same kind of principle, namely, don't think of your patients or the activities as a homogeneous mass, but try to see if there are subgroups that in some important way are homogeneous internally, and then go for one of these and try to develop a solution. That helps. Here's a model that we have worked with in care planning for elderly people. So we have two variables. First, the severity or duration of the problem, short-term, long-term, and then patient capabilities to cooperate. And this gives you 4 different types of patients and patient situations that, as you can see, require rather different approaches. Okay, the lean healthcare thing that I guess many of you are familiar with operates mainly in these 2 parts of the business model canvas, key resources and key activities. So let me spend a few minutes talking about processes, because service production processes are typically the sort of thing that is improved. So if your process works better, you can save money, you can offer better care, you can attract more patients, you can provide a better working employment for your staff. So in the DSO model, I think that there are essentially 4 different kind of processes. The emergency departments are different from everything else. They operate what is called time-critical job shops. So that's complicated. Let's not go now into that. Then there are these processes connected to one visits and electives that are plannable from beginning to an end. And this is sort of car factory kind of thing, to which all the principles of lean can well be adapted. Then we have the processes that are typical in QRM projects, where you don't know at the beginning how this will end, and you can plan only 2 or 3 steps ahead, and then you have to do iterations and deliberations and all that. So this creates a very different environment compared to the plannable to the end car factory environment. This is more like content production, software writing, creative work, and so on. And then there is a continuous process thing that is typical in prevention and in care. That means that the process is not discrete in the sense that there are different steps. The process goes on all the time. It's like a petrochemical plant where some stuff is in the pipeline all the time. So in the same sense, patients are in a care system all the time, and then it's this continuity that needs to be managed. So let's talk about this plannable to an end. There are 2 ways to look at processes. This is classical industrial management. You can look at the flow unit, meaning the thing or the customer that is processed, and then you can look at as the relationship between setup and processing. So the flow unit movement gives these classical kinds of process structures, the job shop that is used in emergencies, then the disconnected flow is most common in industry, and then the connected flow, and then the continuous flow. So typical to all this is that there are the standardized. The objective of process development is to move towards the connected flow, where the flow unit is in motion all the time. So things happen all the time. There are no interruptions. Everything groups through sort of putting the process forward. So as in the introduction, Karval mentioned this my little episode that made me think about healthcare improvement. So that was an instance of a disconnected flow where I, as a patient, went to one workstation. I saw a doctor, and something was done and said and whatever. But then I was handed over not to the next doctor or nurse or emergency center, but I went to an inventory where I waited for somebody to call me up for the next thing to happen. And when you spend more time in inventory than at the workstation, then it doesn't sort of feel really good. This is a sort of classical operations management problem. There's a huge literature on this topic. If you feel that your situation is like that, then there's a lot to learn. But then this I find intriguing. The other perspective, namely in all processes, you have to first sort of think what you do and then you do. In the technical term for this is processing. Processing is the actual changing of the state of a flow unit. So in a factory, when you take off shavings on a piece of metal, then you change the state of that piece, and that is processing. But before you can do that, you have to set up the machinery. So you have to fix the workpiece and the tools and everything, and decide in your mind what you're going to do. So that's the setup. And then you have to have some physical preparations on the facility. Now, the interesting question in all industrial, let me stop here for a while. When we talk about innovation, particular digital innovations in healthcare, I think an important distinction is that innovation touching the setup or is it touching the processing? Namely, if it touches the setup, there will be a very different dynamics compared to a situation where it touches the processing. The processing thing, that's clinical interventions. These are typically medical innovations that change the way doctors do something. So that goes over to the medtech. From a management perspective, the interesting innovations are those where new information is available for the setup so that it can be done in a different way, faster and more accurately. Then, of course, many innovations can be done in this infrastructure thing, like resource allocation, staffing, scheduling, daily management. That's sort of classical management, and then in logistics. Oh wow, it dropped me from. Oh, I got a little repeat now. I need to get to the next one here. Okay, so this is very fundamental. This is actually the logical foundation of mass production and economies of scale. The idea is that in the standard process, you do a setup once and then you repeat. Setups are expensive to do. So if you can share the cost of a setup over several repetitions, you will save money. And this is how mass production industries work. At the other opposite end, you have the non-routine explorative processes where you don't have a sort of clear scheme. You go from one incident to another, and you sort of keep setuping all the time. And these are chaotic processes that we see a lot in healthcare. But then in the middle, there are the two things that kind of processes that are very interesting as social development. If a non-routine explorative process starts to stabilize, so that you keep repeating things in a similar, almost similar way, then we talk about routine processes. But then there is a way to go further and format the setup. And this is where I believe digital technologies have a great deal of potential in healthcare. I'm working, for example, with a company in Finland called Kaiku that is developing this kind of mobile phone-based anamnesis methods, which means that if you need to go see a doctor in primary care, so you do your scheduling appointment on a mobile phone, and then the system starts to ask you various kind of questions that why do you need to see the doctor, what's the problem with you, and then there is an element of artificial intelligence that sort through your answers, and it's making a sorting so that the doctor, when you walk in, can be sort of better prepared to what you are going to say and what you're going to need. So that's technology that helps doing the setup in a more sort of precise and economically efficient way. So I believe there is a great deal of potential in this area. So, okay, I need to wrap it up and say that ultimately, for something being really innovative and useful in healthcare, there must be some relation between the innovation and the caring relationship. The caring relationship between doctor or patient, that's where the value creation in healthcare really happens. If an innovation is not touching that in a way or another, then you can ask whether it's innovation. And then the other issue is, of course, all these things of cost. How much does it cost? And value, as we know, is the relationship between health outcomes and total cost. All right, that was it. I'm sure I spent more than my time, so over to the moderator.
All right. I think very thought-provoking presentation, and I would say more than the innovations itself. I think if the people who are listening, if they have understood at least the logic of not treating the whole healthcare just as one particular homogeneous thing, but as they are very different entities. So, like emergency is naturally a very different thing than a one-time visit or a process of cure and all that, what he has tried to explain very clearly. And I think the people who are in healthcare then can even understand that even emergency, you can have your own subsegments. I mean, let's say a patient who is coming with chest pain and potential cardiac problem probably is a very different cup of tea than a person who might have come with a severe, even leg injury or a roadside accident. So, because it is all linked to the possibility of death. So, so I think a very, very important lesson that at least I am seeing from the presentation is to understand and divide the kind of activities that are happening in the healthcare organizations so that you can try to create more synergy and solutions towards. Another important thing that a carry home message for us is that let us look at the failures. Let us look at, unless we study the failures, you will not be able to do any innovation. And then let the innovations be for trying to create a solution and then to study the impact that this innovation may have, whether on that particular subject or across many components, like whether it has, like for example, I mean, I would say that a lot of innovations have come about not necessarily for healthcare. I mean, let's say, I would say introduction of WhatsApp, which may be a nuisance in your day-to-day life, but if applied properly, has totally revolutionized the way communication is now happening in the healthcare industry, whether let's say amongst physicians of the same department or between a patient and the doctor who is wanting to send his cardiogram or echo report to his doctor. So you have really, I would say, shortened the time by that kind of innovation, which was not really, it was not intended to help the healthcare, but the innovations today are happening. And I would say, like what he said, that India being in the zone, we are into the catch up kind of situations. We are going to see the maximum amount of these uh, innovations, and that's going to really change, I would say, the way we think and we practice. Let us look at the questions if there are any here.
Yeah, yeah. Alok will ask you, and I have got 3 questions from the crowd. After Alok's question, I'll ask 3 questions from the Paul. Okay.
Yeah, go ahead, sir. Please go ahead.
Alok, you have some, I believe, one question. Can you ask?
One question came up. Paul, it's for you. Can you please elaborate particularly what do you mean by first and second order benefits?
Okay.
I'll repeat it again for you.
Okay. You hear me?
Can you elaborate particularly what do you mean by first and second order benefits?
Okay. First order benefits are those that sort of are immediately connected to the innovation. So if I think of this example I gave you about this mobile telephony based patient anamnesis and reporting thing, the immediate effect is that there is a sort of set of information available when the patient meets the doctor. But when this starts to happen, then the information is also available for the continuous treatment, and that may then have an impact on how the patient process goes after that. And if the patient process starts to say move faster, then certain groups in the personnel might have find out that they have different tasks. So it's like, I think I would say ripples or rings on the water. You have when you drop a stone in a pond, you first have the splash, and then it goes and it gets weaker and weaker. But sometimes the effects on innovation are not only right at the first order. They can be sort of unknown and unintended consequences. That's what I mean.
Okay, Paul, I have received some question and I will ask one by one on their behalf. The first one is, we have heard the theoretical part, what you have presented. We are still trying to understand. Can you tell if you have applied this model in a situation and what was the outcome from the practical angle?
Okay, this is rather, as you said, right? It is a theoretical model, and it can be used and interpreted in many ways. Now, they do some experimentation with different kind of segmentation model. As far as I know, nobody has yet sort of tried to fully use the whole DSO model, but parts of it, or rather sort of applying the principle. So I worked with a primary care clinic that received a lot of sort of patients, and thinking what is the best way to sort of segment the incoming patient stream, and then you sort of follow the not the clinical logic that the doctor will think of, asking, you know, what is the problem with this person, but from a management perspective, asking what kind of resources do I have to activate in order to help this person. So from this follow, since it was primary care, 3 different segments. The first is the segment that I describe as sort of one visit. So here we talk about basically healthy people who have one incident that can be treated with one visit and then possibly a follow-up, but then that is that. So these are easy, and there are a lot of them. But then you have these sort of repeaters who have a problem that sort of keeps coming up, and they then come in a scheduled way or an unscheduled way. And this takes a lot of, say much more resources, because the doctors and nurses have to look into history, the patient history, and then judge based on that what needs to be done. And so this is the second category. But then you have still a third. We need to really find a good name for it, but these are sort of heavy repeaters. I mean, people who have multiple problems and sort of don't stick to the schedules, and sort of need more integrated care, so you need to have a team. So just sort of splitting the incoming patient stream into these sort of 3 channels, so directing them to different resources, helped improve the efficiency and productivity of that place with 20, 30 something processes, and it made for the personnel the work environment a lot sort of more organized and quiet, because orderly, because it didn't sort of mix very different kind of patients in the waiting facilities and so on. So that's one example.
Okay. The second
And
one
I
is,
just
please,
also
please.
to this, I mean, this was a classical thing happening, for example, in our government hospital outpatient, let's say, back when we were doing our outpatients, and there were 300 patients and only 2 hours and 2 or 3 doctors. So one of the things that one of the doctor will go out and say that the patients who just needed to get their medicines repeated should just come out on one side, so that you are singling them out and reducing the thing, exactly like what Paul just said. So definitely, you know, by filtering out people on a certain principle of whether there is no need for a person who is just to repeat his medications to sit and keep on wasting his time and the time of the doctor. So I think definitely, but we didn't think it in that light. I mean, so I think what he's saying is that that becomes like a structured logic around which you can try to filter and classify your patients. Go ahead, sir.
Okay. Yeah. The question is, the lean has been applied in clinical pathways. We have read open heart procedures has been dissected by lean, and they have optimized the cost, time, resource, etc. What relationship of your model of a DSO with the lean is, and how it can be linked up with the DSO.
Yes, my main argument is that lean, so the basic thinking in lean comes from the Japanese car industry. The car industry, the mass production of automobiles is a high volume discrete manufacturing that has a certain kind of logic. Part of that logic is that everything can be standardized, everything follows the laws of physics, every process can be timed and planned in such a detail that you sort of always know what is happening and what's going to happen. So when a huge car plant works following the lean principle, it works like a clockwork. Now, the problem with healthcare is that it's very difficult to replicate this kind of situation for many reasons. First of all, clinical medicine doesn't have the same accuracy as physics, so there are a lot of things that happen that we don't know why and how and what are the consequences. So simply the planability of process in healthcare is on a sort of different level than in healthcare. But in lean, I say there are things that are independent of this, namely some universal principles, like say, always asking, like in the business model cancer, what is the value that you produce, to whom, and how is the thinking processes, how is the process contributing to value? And then lean also says that use teamwork. People are important. Everybody needs to sort of bring their contribution to continuous improvement by using statistical and other scientific methods. I mean, you can't argue with that. That's basically very sound and fundamental universal management. What I see as a problem is that if you try to apply this sort of rather strict process development and standardization and tact time things in environments that really don't allow it, then that creates a lot of frustration, and because it's like putting a round hole in a square hole. So look at the literature on lean production in healthcare. It appears to me that so the best examples come from parts of healthcare where you have something like elective surgery or some, say, diagnostic processes that works very much like a factory, like say imaging or taking lab tests. And to my best of my knowledge, the best lean examples in healthcare come from what is known as surgical factories, where you have factories that specialize on a very narrow range of surgical operations, where they can sort of sort and select the patients, and then they can keep sort of adjusting and honing the process to the utmost. So these kind of surgical factories are, but then again, as you can imagine, they're very different environment from the chaotic emergency clinic where you have no control of the incoming patient flow. So in these things that where you have to think differently, then I would say that the role model is not necessarily the car industry, but it's like say software writing or content production. I mean, go to Bollywood. How do you make a film? What kind of process is that? It's a process where you start from somewhere, you plan a few steps ahead, and then you have to iterate, like you do with a patient with a complex cancer that you believe is curable, but you don't know exactly what is going to work and what not. You have to sort of find your way. So in those environments, obviously sort of teamwork, continuous improvement, all these general principles work, but the sort of strict principles of lean when it comes to, say, standardizing the amount of minutes that you can spend on one tasks and so on and so forth. So that's not going to work very well. But I see there's no basic conflict. It's just that lean is not the universal solution. It's a solution to certain areas of health service production that fits into sort of its worldview.
Thank you, Paul. I have a really comment in my personal experience, and after that, If you have any comment, you can do so. And then I have got one last question, which I have just received it on my mobile. Well, I have done lean in the couple of hospitals in India, abroad, in Asia, US, and UK. In India, particularly because my viewers are most of them are Indians, I've done it in Narayan Hridayalaya, a couple of projects. Biggest thing is as long as you touch the management issue, there is no problem with the people. People I'm seeing, the clinical people. Moment you touch their clinical pathways, that how you should do it, how you should not do it, that is resented by them and not accepted. And definitely, I being from the medical side, they had little soft corner for me for the management fellow. They will not really agree. So really breakthrough into, though I have read the book on clinical pathways, application, lean, etc., has been very difficult with the clinical people because they have their own ways of doing it. And now if you say you change your way like this, like that, it will optimize. That is not taken very kindly by them. So what is your experience on that?
Okay. Yeah, I recognize this problem. I have a lot of respect for the medical profession, and in many ways, I think they are doing the natural thing. So the central message that I'm talking about today is that you could put it this way: medical doctors, when they see a patient or say an incoming stream of patient, they do what they are trained to do. They try to look for what is the problem and what is the solution for this individual and this individual and so on. So the focus on the disease, that is the health problem, and then the clinical solution to that. That's right. But with the DSO model, I address those doctors or other people who are no longer necessarily in the frontline clinical work, but in supervisory positions where they are managers, where they're supposed to organize the activities, where they have to decide about resources, they have to decide about facilities, they have to allocate this resource here and there, and build some protocols and stuff. So the management perspective and the clinical perspective are two different things. I don't see a lot of contradictions between them because both are absolutely necessary. But if you sort of drag clinical logic into the management sphere, then no good things are going to happen. In the same way as if you do the opposite and you try to apply some stilted management principle in the clinical work, then I don't think that's going to work, including this idea that I said that tact times, that you would define by the minute or the second how much time a doctor can spend with one single patient. I mean, that's not going to work. So you have these two areas. Both are important. We cannot live without them. But the management logic side is less well understood, and those people who get in management position, if they come from the clinical background, they sort of need to change something in their mind, and that is a very big challenge that we have to work.
Yeah, the last
My
question. Sorry,
my
sorry.
take on,
Yeah,
Dr. Singh, I think first of all, I agree with your observation that the clinicians become reluctant, and the reason for probably that is that when those changes or the clinical pathways, if a management person is going to talk to them about clinical pathways, is when it is going to be resented maximum. Unfortunately, it is the
yeah,
societies, the specialist societies themselves have to start talking about the clinical pathways and the need for the clinicians to stick to them. I think that's a discussion that we need to have in such a way that the clinicians become the leader of the clinical pathways. Then only probably there may be a success. That's what I think.
yeah, yeah. Thank you. Now, the last question is Professor Venkat of IIM Lucknow. You know him as well.
Yeah.
He says, what is the major difference between lean approach to healthcare and DSO? What is the major difference between lean approach to healthcare and DSO?
Well, there are two different things. They are for different purposes. Lean deals with process management and process improvement. The leading principle of Lean is to reduce waste by identifying carefully where waste is generated. So that's what's Lean. DSO talks about different things. DSO is a sort of structural model that tells you that healthcare is not one. There are the 7 different parts that operate on their own logic. You need to understand what the management logic is in each of these parts. When you've done that, then you can identify, okay, what kind of processes do I have now here when I do, say, prevention? So what's a prevention process like? Then you can go to Lean and say, okay, how do we make a prevention process more lean? So that's, I mean, I don't see a contradiction here in any way. There are two different things. It's a process approach to the thing, and other is a sort of structural, more we could say resource-based way of looking. The DSO model, I mean, applications of it would be something like, say, grouping resources in a different way, like in this example I gave you, that you allocate specific resources for especially demanding patients, why then you allocate a different set of resources for those who only need to renew the prescriptions. So two different things.
In one sentence, one can say is that you can apply Lean in a more effective way by understanding the DSO model.
Exactly.
Okay, thank you very much. I request Dr. Vijay Agrawal to summarize in 1 minute, and because the another 3 minutes we have, 1.5 minutes you can take, and after that I'll take 1 minute to just normal closing the session.
No, I think the last question in a way also becomes like a summary where people have to understand that the what Paul has tried to create is a very clear understanding that you need not think of healthcare as just one thing. You know, when somebody talks of healthcare, even in your own institution, if you are trying to look at a problems, you are not trying to look at solutions, you must think of which segment are you talking about, so that you can use whatever other methods of bringing innovations or applying lean or applying any other methods of creating solutions. You will find that you will have much more success when you start looking at the major segmentation within the hospital rather than applying it without any thought process across the hospital. I think this combination of using, I would say, quality management tools to a kind of a structured classification within a hospital can be a great thing. And I think what General VK Singh also talked about, how do we include clinicians in a way that I agree that they don't have to get involved into the management part, but we need to say that for them to cooperate and collaborate, they need to get on to understanding the clinical pathways and honoring it. So I think overall it was a very illuminating, very energizing kind of a presentation by Paul Lilrank, whom I really consider as to be one of the original thinkers in the field of healthcare. Thank you very much, Paul, and thank you very much, Dr. Singh, for giving me this opportunity to be a part of this webinar.
Thank you very much, Professor Paul. You speaking from Finland in the. You have a lot of snow. We also had a hailstorm. I think, effect has come here as well for last couple of days. Thank you, Dr. Vijay Agrawal, for moderating it so well, and thank you, viewers. That I presume and I hope that you have gathered some good ideas to implement, and we will request that you kindly do give us a feedback so that we take for the next webinars what you want to hear and what you want to. We have many initiatives, and maybe you may like to you might to take part in those initiatives. In October, we have annual conference called Health, We have a quarterly magazine called again InnoHealth, where it goes to 41,000 people through Amazon and all other methods. And probably you may like to write some articles. Uh, we have rolled out with the association of Dr. Vijay Agrawal and Cyber for Health. It is already for 1 day we have done. We are also doing now 2 days rollout, which is ready. Then we are also doing it for Ministry of Defense. This is a course for 2 days and 4 days on cyber security. Sachin is not here, is away. He is the main resource person. So, and we have Innovators Club, where we have same 40 kind of a people, 30, 40 members who sit down and work out half a day followed by lunch. And the webinar, of course, you can be informed and you will be told you want your name to be included in our database. You'll be most welcome. Thank you very much for all of them. And thank you for my back team of Alok and other people who have done this webinar. Okay, thank you. We are closing it. Thank you, Alok. Over.
Thank you. Thank you.